Guys, welcome back from the break. Hopefully you're going to take a listen to this before too long. I think we start this either day 2 or the week that I'm on vacation. Not sure. Anyway, this deals with chapter 10. It's kind of going over, you're going to recognize the positions and the centering is basically the same as the chest x-ray for some of these. It is the bony thorax or the ribs and sternum lecture. Sometimes I'll refer to the unit as the ribs and sternum, which is the entire bony thorax. So let's get into it. Okay, so first thing you need to know about ribs. I apologize to those people that don't eat pork, but you can also eat beef ribs. So this recipe is in fact for baby back ribs pork, so you might have to adjust it if you're eating beef ribs. You want to use a good hardwood, like a hickory is pretty good, cherry is really good, any of your fruit tree hardwoods are really good. Stay away from mesquite that's actually got carcinogens in the smoke. And other toxins, so don't use mesquite wood to smoke your meats. You're actually poisoning yourself when you do that. Proper smoking is keeping the temperature in the smoker between 200 and 250 degrees. You don't want to char the meat. You want to infuse it with smoke and warm it up like it's in a slow cooker or an oven. Okay, it's kind of like baking your ribs, but you're also infusing with smoke. Okay, again, hardwood trees are going to give you the best smoke flavor. This is Tennessee. We do Memphis dry rub around here. Make sure you pick that membrane if you're doing those ribs. It's the membrane on the inside. That would be the, if you're wanting to know, that is the parietal peritoneum. No, parietal pleura, rather, that you're picking. So if you've ever prepared ribs and you know what I mean by pick the membrane, yeah, that is the parietal pleura that you're actually pulling off of the inside of the rib cage. You have to do that or else your ribs are going to be really chewy if you don't pull that membrane off. Okay? Dry rub with a mix of spices. You can go to Kroger or Publix or wherever and they'll have dry rub spices that in several flavors. I usually prefer something that's got a brown sugar or a bourbon flavor to it. Slather with a quality barbecue sauce, and don't be afraid to get a little creative with that. It doesn't have to be a tomato-based barbecue sauce. Carolina barbecue sauce is actually mustard base instead of tomato base, and it is fantastic. Alabama white kind of more reminds me of a gravy than an actual barbecue sauce, but it's very peppery. It's very nice. I have tried it. I'm not going to turn it down if it's offered to me, but it's not my favorite. I would go with either conventional barbecue sauce or the Carolina mustard-based barbecue sauce myself. So anyway, now let's get on to the actual ribs and sternum content. All right, so our objectives, just like any other procedures lecture, we are going to start with anatomy, then we'll talk about general procedure considerations, and we're going back to the thorax, so it'll be similar to what you saw for chest x-rays at the beginning of the curriculum. We will talk about general radiation safety protection practices. There's no reason not to shield everybody for ribs and sternum exams. The gonads are well away from the area of interest. You should be able to shield just fine. Proper use of positioning aids. A 45-degree angle sponge would come in handy for oblique ribs if you're not doing them standing. Typically, we're going to do these evaluations standing if the patient can tolerate it, because that drops the diaphragm lower and we get a better view of the upper ribs in a standing projection. Okay. Demonstration, that's going to come in lab. We will practice. I will show you how to do the ribs and sternum series, and then we'll practice some. And then we'll have image critique and I'll show you some rib exams and what we did good and what we did bad and so on and so forth. Okay. And we're going to start injecting a little bit of science. There is the blurred edge penumbra relation to OID creeps into this lecture, so be watching for that. That's coming up on one of these slides. I have that in there because so often ribs are hairline fractures, and you can literally blur them out if you don't know what you're doing. All right, so starting with our anatomy, typically we have 12 pairs of ribs, unless your name is Adam, and then one appears to be missing. And those correspond to the 12 thoracic vertebrae. Now the ribs have 3 classifications. The entire bony thorax is kind of cone-shaped. Can be barrel-shaped with some pathologies, but it starts out cone-shaped. So tapers at the top. The first rib circumference is very, very small compared to the 8th or the 9th rib circumference. So the ribs expand in circumference as they descend all the way down to the 8th and 9th and technically the 10th rib. We don't include the 11th and 12th because they don't connect back around to the sternum. So yeah. So what is the bony thorax for? The rib cage and the sternum complex? Well, it protects your heart and lungs from contusions and abrasions if you happen to bump up against something, or if, God forbid, you fall down, or if you're in any other kind of accident. The rib cage is meant to absorb physical shocks and prevent damage to your internal organs. Okay? It supports the wall of the pleural cavity in the diaphragm. It gives a nice framework for the lungs to hang off of. And so I just mentioned the parietal pleura membrane coats the inside of the ribs. It sticks to both the ribs and the periosteum of the ribs, but also covers the intercostal muscles too, in between the ribs. And so a very slippery surface on the inside of the rib cage all the way around so that the visceral organs, your lungs in particular and your heart, can move freely past the rib cage while also being supported by it. Ribs flex upward and outward during the breathing cycle via the intercostal muscles. In order to expand the rib cage and therefore expand the volume of the chest. That's for an inspiration, but they can also, those intercostal muscles can contract and draw the rib cage in and make the volume smaller, and that's for exhalation. So here's our anterior aspect. You can see the first through 12th ribs are labeled, and you can't see it on this diagram except for the 12th rib articulates with T12, and then the 11th with T11, and so on and so forth. You can see all the way at the top. The sternum blocks your view of anything beyond that, all the way up till T1. And some of the parts of the sternum we're already familiar with. We know the jugular notch. The sternoclavicular joint is formed at the top of the sternum. The sternoclavicular joint includes the proximal end of the clavicle, but also the cartilage of the first rib, joining with the manubrium, or the head of the sternum. Kind of looks like a sheriff's badge. Not necessarily here on this, but on a radiograph it really does look like a tin star sheriff badge. So the manubrium junctions with the body of the sternum at the sternal angle. Is also where the second rib cartilage joins with the sternum, and then you have the third, fourth, fifth, sixth, and seventh all join to the body of the sternum. The 8th, 9th, and 10th technically do not join directly to the sternum. They join to the cartilage of the 7th rib. So it's an indirect connection back to the sternum. And then the 11th and 12th do not have anterior cartilage. So you can see that anterior cartilage and kind of a gray look to it. And then the final portion of the sternum, the xiphoid process, descends below the body, and that's at about the level of T9, T10. Okay, sternal angle is about the level of thoracic body number 4, and then the clavicular notch the sternal notch or jugular notch at the top of the manubrium is at the level of T2, T3. Okay. Yes, the anterior cartilage is called the costal cartilage. Costal means pertaining to the rib. So there, now it advanced. All right, sorry, the font's a little small on this one. So here's our parts of our sternum. It is centered to the anterior midline. So you'll find it on the mid-sagittal plane. It will be superimposed for your straight AP views. It'll be superimposed on the spine. That and the fact that it's a flat bone makes it very difficult to see. So we don't actually do a straight AP or PA of the sternum. We're going to do a slight oblique to roll the sternum off of superimposition with the spine and the vertebral bodies, and then you can visualize it a little bit better on an X-ray exam. Okay. The sternum is approximately 6 inches long, and there's 3 parts. The manubrium, which is also called the head of the sternum, or the most superior aspect, the body, and then the xiphoid process. Okay. It is palpable in 3 different locations. The jugular notch and the sternoclavicular joints are palpable at the top. The sternal angle is palpable, and the xiphoid process is palpable. Okay. Remember, when you are palpating, make sure that you warn your patient in advance what you're doing and why you're doing it, just so there's no confusion. All right. And then the lateral aspect, this diagram is nearly useless, except it shows you where the cartilage attachments are found on the side of the sternum. So the sternoclavicular joints at the top of the manubrium are of particular importance. We'll have special radiographs or projections to learn to isolate sternoclavicular joints. Those are also going to be slight obliques. And also there might be a quiz question about where do the costocartilages attach. In particular, the second costocartilage attaches right at the sternal angle, so that might be a quiz question that you would see, or a registry question. Okay. Here is a close-up of the manubrium and the sternoclavicular joint. The jugular notch or sternal notch is at the level of T2, T3. Okay. The body of the sternum is about 4 inches long. The entire sternum is about 6 inches long. The body joins with the manubrium at the sternal angle. There is a little bulge there in the bone, and you can actually feel that, palpate that, and that's at T4, T5. And then the xiphoid is usually found by tracing the lower rib cage up to where the conflux of the anterior rib cartilage forms at the bottom of the rib cage. That's usually the easiest way to locate the xiphoid process. And if you are squeamish about touching the patient's chest, the patient can very easily find their own xiphoid. Don't tell them to find the xiphoid, tell them to find the bottom of the rib cage. and walk their fingers in toward the midline, and that will be a good approximation of where the xiphoid is. So, give me just a second here. All right, guys. So parts of the rib, this is actually looking at it from the back. So the head of the rib is the most posterior part. On the head of the rib is the facet for articulation with vertebral body. Then it narrows a little bit. So what do we call a narrowing just beyond the head? Yes, that's the neck. And then there's a tubercle just under the neck of the rib. And the tubercle has a secondary facet that articulates with the transverse process of the thoracic vertebrae. And then we get the axillary portion, which is the angle of the rib where it curves maximally. On the inside, there is a groove called the costal groove. That's on the inside of the angle. And then the body of the rib wraps anteriorly. Okay. Ribs are 12 in number, and like it says, it corresponds to the articulation with its corresponding thoracic body. The ribs are not all the same size and the same curvature and the same diameter, I guess, or half diameter. The first rib is the shortest and the broadest, and then they keep getting larger and larger arcs, I would say, increasing all the way up to rib number 7 and then decreasing again down to rib number 12. There's 3 sections of the rib cage, and they're classified by how they attach to other structures. So all the ribs attach to vertebral bodies. The true ribs also have a cartilage attachment directly to the body of the sternum, and that would be ribs 1 through 7. False ribs, pairs 8 to 12, attach indirectly to the sternum or not at all. Okay? So they don't have a, see, and this slide is actually wrong. This is the slide from Merrill's Atlas. False ribs is not classified as an indirect attachment to the sternum because 11 and 12 are also false ribs, but they don't have an indirect attachment to the sternum. So false ribs are better classified as not having a direct attachment to the sternum. And then as a subset of the false ribs, the floating ribs, 11 and 12, are said to float because they don't have anterior cartilage at all. They don't even attempt to make contact with the sternum either directly or indirectly. All right, moving right along. This picture, again, we've got a head, a neck, a tubercle, and a body, and an angle. Okay, so this picture illustrates how does the rib junction and articulate with the thoracic vertebra, excuse me. So there's the vertebral body, and the medical terminology word for rib is costo. Okay, that's the root for rib. And then vertebra is the root for vertebra, obviously. So when you combine those two, costovertebral joint, that's the articulation between the head of the rib and the back corner of the vertebral body. And you might have remembered from the thoracic spine lecture that the thoracic bodies have demifacets. or half facets. And that is because the head of the rib actually articulates to the disc space halfway between one level and another level. Okay? So one actually articulates to the bottom of one and the top of two. Rib number 2 actually articulates to the bottom of 2 and the top of 3, and so on and so forth. Okay. So those are the costovertebral joints. You have to keep them separate from the costotransverse joints. So there's the head, then there's a tapering and it's a neck, and then under, I guess, posterior to the neck and the head is the tubercle of the rib, and that's got another facet. The facet on the tubercle of the rib articulates with the transverse process of the T-spine, of the vertebrae, of the T-spine vertebrae. Okay, so that one's called, it's rib plus transverse process articulation, so it's a costotransverse articulation or joint. Okay, remember joint and articulation are synonyms. Okay, so two different types of joints there, and you'll definitely be quizzed. I would expect this diagram to be on there or something similar to this diagram to be on there, and I'm going to expect you to tell me whether I'm pointing to or indicating the costovertebral joint or the costotransverse joint. So that's fair game for an upcoming quiz or exam or even the registry. Make sure you know the differences between those two joints. And then anteriorly, technically the cartilage is called a costocartilaginous joint. So, all right, general procedure guidelines. I think we start with the ribs. Because you know I did go over some of the sternum, but I think we start with rib projections. I'm not sure. It's been about 2 weeks since I built this PowerPoint. That was before the site visit, so bear with me. Let's see what we jump into. Okay. Oh, look, a review question. Which ribs are true ribs again? Was it 1 through 7, 2 through 8, 8 through 12, or all ribs are true ribs? Well, it's definitely not all ribs, and 2 through 8 doesn't mean what's special about number 1 that it wouldn't be classified. The right answer is actually 1 through 7 are the true ribs, 8 through 12 are called false ribs, and then 11 and 12 are called floating ribs for your review. So make sure you have those categories set. I'm sure there's a question about those categories. Maybe even more than one. Our general procedure guidelines. Patient preparation can be similar to what we see for a chest x-ray. Hanging earrings, anything close to the clavicle, especially when we're doing ribs. Yeah, clavicle is worthy of incidental finding on a rib injury x-ray. So if we're doing a rib procedure, yeah, most of the clavicle should be included in the collimated field. Not necessarily all the shoulder, but most 90% of the clavicle should be included. So we don't want dangling earrings. Stud earrings are fine. The patient can leave those in. We're going to look for piercings. We're going to look for necklaces. We're going to ask about those things. If the patient is wearing a shirt with buttons, either at the collar or down the front or what have you, or a zipper in the back, those have to be removed. For both ribs and sternum, bras will produce several artifacts, the hooks in the back, the underwire, all of those things will produce artifact overlying pertinent anatomy, and so bras should be removed. Generally, your patient, if they can tolerate it, will do all these exams upright. It's just easier on the patient, unless they've been in a motor vehicle accident and they're not able to stand. You're going to get a better examination with them upright. The other consideration is your patient strong enough, your geriatric population? Can they stand up for an extended period of time? That would be another consideration to do them supine. It's perfectly acceptable to do a rib or sternum series, supine or prone as the case may be, rather than upright, but the lion's share of your clinical practice you're going to be doing these exams upright. For the lateral sternum, we're going to need a 72-inch SID. IR collimated field size for your rib x-rays, you're probably going to be using 14 by 17 field of view. You could collimate that to a half, so it'd be like 17 by 7 field of view if you're only doing a unilateral rib x-ray. Your sternum will fit on 10 by 12 field of views, no problem, both your PA oblique and your lateral sternum projections. And then SC joints will fit on a 4 by 4 square. Source to image receptor distance, we only need to adjust for the lateral sternum. All other projections we ought to be able to do at 40 inches. There is going to be magnification of the ribs that are side away from the image receptor, whether we're doing, if we're doing PA ribs, the patient has their back against the image receptor, and the anterior ribs are going to be magnified and blurry, similar to what they show up like on a chest x-ray. If we're looking at an anterior injury, we're going to want to do a set of PA ribs, and then the posterior ribs will be magnified and blurry. But the anterior ribs will have nice crisp edges and will not feature any magnification. For your sternum, the preferred projection, instead of an AP or PA, you want to do a slight PA oblique in an RAO. That's going to shift the sternum over the heart muscle, give it a little bit of help with attenuation, and make it show up just a little bit better with a heart muscle in the background. You can do an LAO, but it doesn't show up as well because the sternum doesn't have a lot of calcium and a lot of bone matrix to it. So, radiation protection, no reason to not shield anybody for ribs and sternum exams. The gonads, the reproductive organs, are well away from the area of interest. A standing shield can be brought to the level of the iliac crest, and it will be below the pertinent anatomy. And your patient instructions, you are going to have different breathing instructions for different projections. I'll do my best to remember those as I'm describing them. Upper ribs are always deep inspiration and hold. Lower ribs are always expiration and hold. The sternum has a variety of breathing instructions. It's deep inspiration on the lateral, but it could be a breathing technique or expiration and hold for the PA oblique and the sternoclavicular joints. So, your patient preparation, removal of artifacts from the area of interest. So this includes your necklaces, your clothing artifacts. Ask about nipple piercings. They may be reluctant to remove those, so make sure you ask and make sure you document that you did request their removal. Those will adversely affect any rib examinations. The presence of nipple piercings will produce a superimposing artifact that may hide a hairline fracture. Okay. Hopefully adding in some obliques will shift their position, and you might be able to get away with not removing them. But you should also offer advice to your patient that it adversely affects the ability of the doctor to diagnose if the nipple piercings are left in. The conversations we have to have. Lord have mercy. All right, give me a second, I gotta get a drink. All right, general patient position. Again, we're going to want to assess our patient on the front end. Are they fit enough to stand for the exam? And can they stand still without swaying in the breeze? These are basically the indicators you're looking for. It's going to be much easier on you if your patient can stand up, but it's not impossible to do ribs and sternum exams on the table, in the table bucky. Okay? So your non-ambulatory patients, those that are not strong enough or don't have the stamina to stand up, and those that have just been in a car wreck or some other traumatic injury event, and it's not wise to stand them up, should have no problem doing these exams on the table. Okay. Now, time's probably not going to allow for me to demonstrate those both, but I do have a trauma lecture coming up for RAB Procedures 3, and so we're going to go back and revisit a lot of the stuff that we did upright, and I'm going to go back and just show you real quick how would you pull that off if your patient was AP supine on a backboard and you couldn't roll them or move them or anything. I'll show you how to do a lot of the trauma projections during the trauma unit in our trauma lab. So, IR collimated field size, use smallest image receptor that will demonstrate the anatomy. Typically, you guys are going to be working with a DR plate, so it's more like how far down do you collimate. Again, my recommendations for the ribs, 14 by 17 in various orientations, either portrait or landscape, depending upon what projection you're doing. But all your sternum projections can fit into a 10 by 12 field or less. So, and your sternoclavicular joints can fit into about 4 by 4 square. All right, here's our SID. 30 inches is recommended for a PA oblique sternum. Good luck getting your software override to allow such a short SID. I'm going to show you how to do it at 40 inches, not 30 inches. 72-inch SID is recommended for lateral sternum. Same problem that we have with the C-spine is that there's OID by the downside shoulder, usually the left side shoulder. And so to reduce magnification of the lateral sternum, we're going to increase the SID to 72 inches to try to combat that magnification effect. ID markers, obviously, we're going to need to distinguish between the right and the left rib cage. The sternum really is centered to the midline. You're still going to need a right or left indicator on your PA projection. You should probably be doing a right indicator since you're most often doing the RAO for the PA oblique sternum. And then also you want to mark side down for any lateral projections of the sternum. So, and also mark side down for your oblique ribs. Avoid using digital annotation post-processing. That does not meet the legal standard for identification of the image because that marker can be altered post-examination. Okay. Other required ID markers, it should identify the patient's name, date of birth, what facility they had the x-ray in, what type of study it was, who the ordering physician was, the patient's medical record number, and the accession number for the examination should all be reported in the corners of the image when it's sent to PACS. Radiation protection. Patients should be protected from unnecessary radiation, and there's a couple strategies for this. We need to shield, obviously, shield the gonads. The areas of interest for all these exams in this unit are nowhere near the reproductive organs, no reason not to shield. The other things you can do is, how about not exposing all the tissue, just expose the tissue that is necessary to demonstrate for the particular exam. So here you see the 4x4 collimation for the sternoclavicular joint. If they're ordering a sternoclavicular joint, that's to be in the center of the image, and they only need a 4x4 square. If the doctor wants an entire clavicle, he can order a clavicle series. That's a different evaluation than a sternoclavicular joint. Okay? Optimal technique factors, you should select a recommended technique according to the APR. If you have a reliable APR software, APR stands for Anatomically Programmed Radiography. That's a registry question. You should have a manual technique for all these projections. As you watch technologists do ribs and sternum, you are going to find that they use AEC for the ribs, possibly AEC for the PA sternum. AEC is probably not available for lateral sternum. That's probably going to be a manual technique. You can look up technique guidance in the Merrill's Atlas. They'll have representative techniques there. You should be adjusting your technique for pathology and for habitus. So increase the kilovoltage if you find that your patient is hypersthenic. Decrease the kilovoltage if you find that your patient is arthritic, geriatric, and or asthenic or hypersthenic. Okay? And so using an optimal technique ensures that you get a good deviation index, a good exposure index, and you don't have to repeat for model. Using close collimation controls scatter, so it controls your subject contrast, that is your raw data contrast, and makes it more likely that the image will be diagnostic and displaying with proper contrast and brightness. Okay. Use an appropriate kilovoltage to ensure adequate penetration of the part, and the kilovoltage should be proportional to part thickness, regardless of what body part or projection you are attempting. Right, we have another review question. What is the most inferior portion of the sternum? Is it the manubrium, the jugular notch, the body, or the xiphoid? This one's fairly easy. It is the xiphoid. The manubrium, remember, is the head of the sternum. The jugular notch is at the opposite end. That's the most superior portion. And so this could be formulated as a quiz question, but then I could change the word inferior to superior, and then jugular notch would be the right answer. Right? The body lies in the middle of the sternum between the manubrium and the xiphoid, so that can't possibly be the most inferior or the most superior portion. Right, our patient instructions. Explain and demonstrate positions when possible, so modeling is going to come in handy. You guys remember modeling? I taught it to you when we learned the chest x-ray. Just step into the position that you want the patient in and just say, I want you to stand like this, facing my board here. Raise your chin up and roll your shoulders in. And then step out of the way and watch the patient do that. Okay? Modeling is extremely effective when there's a language barrier, and your ability to convey instructions is compromised by that language barrier. Okay? Respiration instructions are essential for imaging of the bony thorax. Okay? There's going to be some times that we want the diaphragm to descend, like for this projection here, which is upper ribs PA projection, to well visualize anterior ribs in this projection. It's a bilateral examination. It looks like a chest x-ray for all intents and purposes. It is a chest x-ray. The only thing that is different than a chest x-ray is the technique. You're not going to shoot with high kilovoltage. You're going to shoot with low kilovoltage, high mass. And the processing is going to process not so you can see the lungs really good, so you can see the ribs really good. Okay, so it changes the processing algorithm. Everything else is and the kilovoltage technique. You don't want high penetration because you want the ribs to actually attenuate and absorb those low energy photons. Remember, photoelectric effect is more probable with low kV. The ribs are really thin, okay? They're not very broad in diameter. And so in order to promote photoelectric absorption, we need the average beam energy to be very low, so we get a good photoelectric response from the calcium that is in the thin ribs, okay? Sometimes we want full inspiration, diaphragm descended, sometimes, but what that also does is it engorges pulmonary vessels, and so we want the opposite for the sternum, because we don't want a lot of the sternum overlies the hilum, and we don't want the hilum to be thick and engorged. And so we want expiration typically for our sternum and our sternoclavicular joints. Starting with our central projections of the sternum, we want to do a PA oblique, RAO in particular, and a lateral projection. Here we see a recumbent lateral projection. If the patient's been in a car wreck and had an airbag deployment against the sternum might be bruised, or there might be a tearing of the costal cartilage. And in that case, you would probably want to do them laying down. They should be able to tolerate that better than standing up. Okay, and you don't know what other injuries. They might have injuries to their lower extremities as well if they were in a vehicle accident with airbag deployment. So just be thorough with your assessment so you can determine whether or not the patient's fit to stand. All your sternum projections are going to fit on 10 by 12 fields. Your lateral can even be collimated in side to side. Okay, starting with the PA oblique. Now the book does say you can do both an RAO and an LAO. I isolate the RAO typically because that's all they ask for. They only ask for one of the obliques in most protocols, and it's the RAO. When you shift the patient into a slight RAO, the sternum is going to move off of the spine and over top of the heart shadow on the left side of the chest. Okay, the spine being posterior is going to shift to the patient's right, but the sternum being anterior is actually going to shift to the patient's left. We need about 15 to 20 degrees of rotation to achieve this effect and get the sternum off of the spine and remove that superimposition. Make sure the shoulders and the hips are rotated equally. We don't want them to just rotate at the shoulders. So a shallow angle sponge under the elevated hip might help with stability. And you can flex the left arm and have them push off with it and support themselves with their left forearm as the model is demonstrating here. Okay. Make sure your patient is running down the long axis of the table or is standing straight up and down and not leaning to the left or right, because that will affect how the sternum is oriented relative to your image receptor. Okay, there is no tube angle. It's a 40-inch SID. Actually, it's 30-inch SID, but most of your modern machines will have a safety override and will not actually let you shoot at 30 inches. So the book can recommend it all day long, but it looks like the software controls typically don't allow it on our modern machines to shoot with a 30-inch SID. So 40 inches will be just fine. A 30-inch SID is going to have the effect of magnifying your sternum without losing edge detail. So, where do you center? Well, the patient's going to be in a prone oblique, so it's going to be hard to figure out where you're centering. It is going to correspond roughly to the inferior angle, the level of the inferior angle of the sternum at T7. You should be able to figure out where the sternal notch is. You should still be able to visualize that under the patient, even if you can't palpate for it. Just extend your light field to 1.5 inches superior to that jugular notch, okay? And your centering should be roughly T7, which is where we centered for the chest X-ray. So your central ray, perpendicular to the image center, enters the elevated side of the posterior thorax 1 inch lateral to the mid-sagittal plane at the level of T7. And we have two representative examples of this oblique sternum. We have one where the patient held their breath, and you can see the pulmonary markings, the vasculature of the hilum obscuring and making visualization of the body of the sternum extremely difficult in that upper radiograph. But if we use a breathing technique, and remember, a breathing technique just means you reconfigure your MA and your time to the lowest MA station possible to allow for at least a 2-second exposure, and your patient breathes normally through that exposure. It does say slow, shallow breaths during the exposure. What that's going to do is not necessarily blur the ribs this time, but the lung markings are going to blur out quite a bit. If you are just using a suspended breath, make sure it's suspended at the end of expiration, because inspiration allows for dilation of the pulmonary vasculature, and so all the vascular artifacts that are overlying the body of the sternum, all those blood vessels will get thicker if you tell them to take in a deep breath and hold it, and so you really won't see the sternum. It'll be quite superimposed. Both of these are overlapping the aortic arch and the heart muscle, and that actually makes for a decent contrast and makes it so you don't overpenetrate the sternum, which is really, really easy to do. It doesn't have much in the way of bone matrix. Okay. For our lateral sternum, stand the patient up if you can. If the patient's laying down, they can lay flat on their back with a horizontal beam projection and a vertical image receptor, dorsal decubitus, or you can roll them up on their side. It really depends on whether or not they also have a rib cage injury, okay, and whether or not and how they're able to move their arms, okay. It does say that the breast tissue of female patients will get in the way of the lateral sternum. The best way to shoot a lateral sternum with a patient with large breasts is the dorsal decubitus projection. The breasts tend to, with the arms elevated, the breasts tend to fall off to the side, and that will effectively thin the breast tissue at the anterior chest wall. Okay. If you're having them stand up, we don't actually raise the arms over the head. We actually tuck those behind the patient's back with the fingers laced. Okay, like this. Okay, so fingers laced behind the back, and rotate the shoulders posteriorly. So they're going to like puff their chest out and arch their shoulders back as they have their fingers threaded behind their back or tucked behind their back. Okay. Obviously, your patient has to be flexible enough to perform this procedure. If you don't feel that they can do a decent job with this, you can have them raise their arms up, and that would be the next best position. Okay. We do want to center just a little bit posterior to the sternum. If you center to the sternum, you're going to have way too much primary beam, and you're going to burn out the sternum. You actually want to center to about 1 inch anterior to the mid-coronal plane, between the mid-coronal plane and the anterior chest wall. Okay. You want to expose on deep inspiration to try to achieve separation between the manubrium and the shoulders. Okay, the shoulders will superimpose the manubrium if you don't get a good rotation of those shoulders posteriorly and a good deep breath in. Okay. Top of the image receptor, again, 1.5 inches above the jugular notch, centering to 1 inch anterior of the midcoronal plane at the level of about T7 or the level of the mid-sternum, because now you should be able to visualize the xiphoid and the jugular notch and be able to center to halfway between both of those levels. All right, so what anatomy and projection is this? Yes, this is the sternum. Oh, look, I've made it anonymous so you can't see what the labeled anatomy is. I wonder if this would show up on a quiz question. Okay. So first of all, is this a PA oblique sternum? Is this an SC joint projection? Is this a lateral sternum projection? Or is it AP oblique of ribs above the diaphragm? It is the PA oblique sternum. And let me indicate, so you see all these anatomy lines? I'm going from the most superior, the top one, that is the clavicle. That's the proximal end of the clavicle coming in. And then the second line down is the jugular notch. Okay. The sternoclavicular joint looks like the patient's right sternoclavicular joint is the third line down. Okay. The first rib anterior cartilage on the left is the fourth line down. The manubrium is the fifth line down. The sternal angle appears at the sixth line from the top. Okay. And then the body of the sternum is the seventh line, and then the final line is the xiphoid process. Okay. You can identify the body because it's got the Rambo knife shape. It's got those little sawtooth articulations, kind of looks like a steak knife or a Rambo knife. And then the manubrium looks like almost like a kid's sheriff's badge on the x-ray. And so that's probably the easiest way to find the sternum. They don't always look this pretty, is to look for the sawtooth side of the body. Look for that Rambo knife side. Okay. All right, for our lateral sternum, wow, this is excellent collimation. I wouldn't even be this brave. We are going to want to see visualization of the sternal angle, the difference between the manubrium and the body. The clavicles will partially superimpose the superior manubrium. The clavicles themselves should be roughly superimposed. We should see some of the anterior ribs and the heart shadow. The body of the sternum should be centered to the radiograph, and we should not clip either the top of the manubrium or the bottom of the xiphoid process. Okay? If the patient is female and they have large breast tissue, you may not see the lower third of the body and the xiphoid process. Again, laying the patient on their back and shooting with a horizontal beam would be the best way to visualize that anatomy on a patient with breast tissue. Okay. Close collimation is going to reduce scatter and improve image quality. You're going to have better contrast visualization with less scatter on the radiograph. Okay. The breathing instructions for the lateral sternum are suspended on deep inspiration. And that's going to move the sternum anteriorly away from the shoulders. All right, guys, for the ribs, now you're not always going to do all of these projections. These are the ones that are most common. Every facility protocol varies just a little bit. Most of them usually include a PA chest. Okay. PA upper anterior ribs, you'll need a PA projection from that. So remember, the ribs that are closest to the image receptor are going to show up with nice crisp edges. There's not going to be much edge blur. and they won't be as magnified. So as we go through all these projections, remember the side closest to the imagery receptor is going to be best demonstrated. So for the PA projection, you're going to best see the anterior ribs, the distal bodies, and the costal cartilage. Okay. For the AP ribs, you're going to best see the posterior ribs, and then the AP and the PA obliques are for seeing the costo angles, that is the rib, the angled portion of the axillary region. Right, so as we learned in October with the paper clips, we saw the paper clips get magnified, but we also saw them get a little fuzzy. Okay, and that fuzzy is called blur or penumbra. And Mr. Shepard is going to go over this with you, but rib projections is one of the studies that gets adversely affected by blur or penumbra. You see, your ribs, everybody's ribs are wrapped in the intracostal muscles. Your rib is actually surrounded by muscle tissue. And so it's kind of bound in place. And so even if you break it, unless you break it with significant force, oftentimes you'll break the rib, but it won't dislocate and it'll form a hairline fracture. It is very, very common for ribs to form hairline fractures because they are shrouded and surrounded with this sheath of intercostal muscle. Kind of holds the rib in place even if it is broken. Okay? And so this hairline fracture is exactly as you would think. It's a very tiny black line that is barely visible on an x-ray. And now if there's blur and penumbra, what's happening to the edge of that black line? Well, it's getting fuzzy. And so there's a real potential, especially with the new digital software. They have an algorithm called smoothing that evens out tiny discrepancies. It is very possible with incorrect positioning, that is, positioning the contusion or the area of interest away from the image receptor, and applying a smoothing algorithm, you can literally Photoshop off, just like the cartoon says, you had a rib fracture, but we fixed it with Photoshop. The blur and the penumbra and the smoothing algorithm can combine to completely erase a hairline fracture in modern radiography. Okay? And so that's why it's important that, number one, you know how to shoot ribs. You always shoot affected side down or affected side closest to the image receptor in order to be able to even visualize a hairline fracture. And then the other thing, in the processing, you do not alter the processing to chest x-ray processing or any other algorithm. You process it as a rib to make sure that there is no smoothing algorithm applied. Okay? So those two things greatly affect whether or not your image is diagnostic, or in fact you're not using the technology correctly and you're actually purposely blurring out a hairline fracture. And Mr. Shepard will talk about that in his REIE class as well. Okay. So for our PA ribs, they can be seated or standing. Upright is the preferred. You can do them recumbent with a patient laying prone. The central ray is directed perpendicular to the level of T7. Shoulders are rolled forward to get the scapula out of the way of the rib cage. Upright with deep inspiration allows for a uniform lung field background on the upper rib cage. Okay. And it allows for if there is a hematoma associated with a rib fracture, it allows for demonstration of an air fluid level, so we could see any hematoma formation related to a rib fracture. Okay. You should do this one so long as the patient is able to stand, taking a deep breath and hold for about 10 seconds. Okay, this is the preferred method. This will show you the anterior ribs and the costal cartilage most effectively. Posterior ribs will be blurry and magnified on this projection. Okay. And so that's what we see. We do see magnified and blurry posterior ribs. Okay. Image receptor, top of the IR, 1.5 inches above the upper border of the shoulders. Everything very similar to a chest x-ray. Rest hands, palms out on the hip, shoulders in same transverse plane. If the patient's prone, rest the head and chin and adjust the mid-sagittal plane to vertical. You don't want them turning their head to the side if they're laying prone, because that's going to obscure, the mandible will obscure the first rib on the side that they turn their head to. So make sure they hyperextend their head and neck and rest their chin on a sponge without obliquing their head. Okay. You'll have a superimposing mandible on the first rib if you don't follow that instruction for the laying down one. Okay. So perpendicular to the center of the IR at T7, there should be no rotation of the body. So patient's mid-sagittal plane should be perpendicular to the image receptor, parallel with the central ray. Collimation to a 14/17. If you're doing a bilateral evaluation, you want to orient typically crosswise for that. If you're doing a unilateral, then you can go lengthwise, and you can shift the center to midway between the axillary border of the ribs and the mid-sagittal plane for a unilateral projection. Okay. Respiration suspended at the end of full inspiration will depress the diaphragm, so you get a more uniform background for the upper 10 ribs or so. Okay. Image critique is going to be, this is going to look so much like a chest x-ray. It's going to be just subtle differences in the contrast. The contrast is a little bit more high contrast than a chest x-ray. Okay. For an posterior projection of the ribs, you can stand them up or lay them down. This time you want the arms elevated. Okay. Patient standing when patient's condition permits to allow the diaphragm to drop lower. Okay. This is going to better visualize your posterior ribs because those are going to be closer to the image receptor, less magnification and less edge blur on your posterior ribs for the AP rib upper projection. Breathing instructions the same. We want a deep inspiration and hold. For this, 40-inch SID directed to the mid-sternum level of T7. Okay. Mid-sagittal plane centered to the midline of the grid. Yes, you are going to need a grid to clean up scatter. Top of the image receptor, 1.5 inches above the upper border of the shoulders. That's before you have them raise their arms up. Rest hands, palms out on the hip. That's for standing. If they're laying down, extend the arms upwards, flex the elbows, rest hands on the back of the head. Okay. Shoulders should be in the same transverse plane. We don't want any rotation of the thorax. Hips and pelvis should also be in the same plane, no rotation. If the pelvis is rotated, then the lower thorax is going to be rotated. Okay, so no obliquity on this one. We should see the PA ribs at least 1 through 9 well presented, or the posterior ribs rather, 1 through 9 well presented on this radiograph. Technique for both of those is going to be, this is for the upper ribs. You're going to want low kV, high mass. In the digital age, about 100 mass will work. Drop your kV. The chest x-ray, excuse me for a second. The chest x-ray, remember our kV is 120 for that. No, that's for penetrating through the ribs and making the ribs appear like they're transparent or glass-like. We want the opposite of that because we're not looking at lung tissue, we're looking at ribs. And so we want low kV to stimulate photoelectric absorption rather than overpenetration. So we want to drop our kV. Typically I did mine at like 66 to 68, maybe 72 for a hypersthenic habitus. But most of my sthenic patients, 66 or 68, depending upon what the machine allows. Okay. Low kV, low energy is going to ensure that we get a lot of absorption of the X-ray by the rib bones themselves. Whereas 120 kV will overpenetrate the ribs, and the ribs won't absorb many of the X-rays at all. Okay. So we're changing the subject contrast by changing the technique. We're making it so it's easier to visualize ribs rather than lung tissue. Okay. For our lower ribs, we actually want to center. Now the center isn't really given. We just understand that the rib cage ends when the pelvis begins, and usually there's 1.5 to 2 inches of squishy between those two. And so the way you center, or the way you line up for lower ribs, is you're basically doing an upper abdomen. You're doing the bottom of the cassette, the 14x17 field, at the level of the iliac crest, and then wherever the center lies, it's somewhere around the xiphoid, but not always. It's really close to the xiphoid. You do not have to get all of the ribs above the diaphragm. You do have to get all the ribs below the diaphragm. For this one, we want to change our breathing instructions. And the breathing instructions will be expiration and hold for the lower ribs. Remember, for the upper ribs, we want to move the diaphragm downward. And so we see all the ribs superimposed by lung field that is overpenetrated. For the lower ribs, we want the diaphragm to raise up, and we want the uniform gray of the abdomen to be the background. And so the technique for lower ribs AP is typically the same technique you would use for an abdomen. We do open the collimation to include the entire torso, side to side. So typically you're looking at 14x17 crosswise. If you're doing a unilateral, you could get away with a 10x12 crosswise. For the lower ribs, they will fit in a 10x12. I've done it before. But if you're scared of that, by all means, shoot with a 14x17. Shifting the center to a unilateral, you just go halfway between the lateral cage and the mid-sagittal plane to center for either the left or the right side rib cage. It's not that complex to figure out. Okay. Breathing instruction is different for upper ribs versus lower ribs. It's exactly opposite. Upper ribs are full inspiration and hold. Lower ribs are expiration and hold. Okay? Make sure you have that straight. That will be a quiz question. All right, oblique ribs. Just got to pose like you're all that, I guess. Where's your sunglasses, dude? Yeah, anyway. Yeah, you want to oblique them 45 degrees. You want basically the axillary portion, which is the armpit portion of the rib cage, closest to the image receptor. So we have the AP obliques, which is actually a posterior. This is an LPO. Don't let that confuse you. AP refers to the projection, that is, the central ray is entering the anterior rib cage, exiting the posterior rib cage. But the oblique indicates that the patient is turned out of true AP. It is a 45-degree angle for this. And then just put their shoulder blade and the armpit area of the ribs up against the image receptor. I would suggest that you have them turn and look away from the side you're imaging. When you do oblique ribs, you can only do left side, you can only do unilateral. So close your collimation to just one side of the ribs. Okay. So it's either going to be a 45-degree RPO or LPO for those AP oblique ribs. Center on the affected side. It's going to be on a sagittal plane halfway between the lateral margin of the rib cage, and the true mid-sagittal plane. Okay? Abduct and elevate the arm of the affected side. You don't want skin fold artifacts through your axillary rib cage. You want them free of superimposition. That'll also raise your scapula up so you can see more of the rib angle in the upper ribs. Okay. The clavicle and the scapula will make it difficult to see ribs number 1, 2, and 3. We just deal with that. Okay. They can rest the elevated arm on the back of their head. They should turn their chin away from the side that you're trying to image so that the mandible doesn't superimpose rib number 1. Perpendicular to the center of the image receptor. Where do you set the image receptor? You're going to orient this for the obliques. It's going to be portrait orientation, so up and down or longitudinal orientation. 14 by 17 cassette, 1.5 inches above the shoulder of the affected side, the side down, before you elevate that shoulder. Right? If you're doing upper obliques, it's deep inspiration and hold. If you're doing lower obliques, it's expiration and hold. What is the degree of obliquity for the AP oblique projection? Yeah, again, not very hard, 45 degrees. Okay. Oh, this is a 40-inch SID for 4 oblique ribs. All the rib projections, 40-inch SID. Okay. Well, look, another question. Which of the following would best demonstrate posterior ribs above the diaphragm? Okay. So do we want a PA projection exposed after inspiration, PA projection exposed after expiration, AP projection exposed after inspiration, or after expiration? Okay? And the right answer is actually the AP projection exposed after inspiration. So we want posterior ribs to show up the best. Well, anatomy shows up the best, and this is a good trick for the registry. Best demonstration means get that anatomy as close as you can to the image receptor, because that's going to minimize magnification and it's going to minimize edge blur recorded in the raw data. Okay? Yes, you can clean some of that up with the post-processing softwares. The edge enhancement and the smoothing cleans some of that up, but you can minimize the manifestation of blur by getting the anatomy in question as close as you can to the image receptor. The one that does that is the AP projection. Remember, AP stands for the central ray enters the anterior, exits the posterior. X-rays travel in a straight line, so the image receptor must be on the posterior side of the patient. So therefore, the posterior ribs are going to be right up against the image receptor for an AP projection. Now, how do you visualize ribs above the diaphragm? What's the breathing instructions for that? Well, you want the diaphragm to drop, so you want a full inspiration. Okay, so that's why the third choice is correct. It incorporates understanding of the breathing instructions, but also understanding of how edge blur and magnification manifest in relation to OID. So there's 2 pieces of knowledge embedded in this question. This is a textbook registry question. You will see a question like this on the registry. They might switch anterior ribs to posterior ribs. They might switch that to axillary ribs of the left side, and then you'd have a bunch of obliques to pick from. The key is the anatomy that they name, that they want best demonstrated, always is closest to the IR. That's the correct position. Well, look, another review question. What projection and anatomy is demonstrated here? Well, this is clearly upper ribs, and it's clearly an oblique. Now, how do you get the spine to shift to the left, but the heart to shift to the right? Okay. This is above the diaphragm, so choice number 2 and choice number 4 are out. Is this an AP oblique or is this a PA oblique? Well, the cute trick is the letter indicator. It looks like the letter R is in its correct orientation. It's not in a backwards orientation. Okay. I would also say that it looks like the posterior ribs are sharp while the anterior ribs are fuzzy. And so I would say that this is an AP oblique projection above the diaphragm. Okay. They've opened the collimation to include the left side, but the area of interest is the right axillary rib cage for this projection. And I'll show you how that manifests. You see how the left ribs are self-superimposed, the anterior aspect and the posterior aspect? You have to look close, but it's there. Whereas the right ribs, you can barely see the anterior aspect. They're rolled out of the way, the oblique. If only we can remove that heart shadow, and then we'd have a really good view. Excuse me. All right, last review question, and I think we hit the summary slide and we're done. Wow, I went through this quick, fairly quick for me. All right, so what projection is this now? Okay. Now it looks to me like the anterior ribs are sharp. Okay, you can see them rolling around the corner. They're the ones that slant. They're slanting in from the axillary regions. It looks like the posterior ribs are magnified. So I'm going to call this a PA projection, ribs above the diaphragm. That's what it looks like to me. Okay. So I'll show you the differences in those. You can't really get a good feel for this. Here you might see better visualization of this on a textbook, in the textbook. But yeah, I still say that the edge of the posterior rib looks a little fuzzy, but the edge of the anterior rib looks nice and sharp. So, and the letter marker's reversed, so that would indicate PA as well. But I'll show you in image critique the difference between an AP projection of the rib cage and a PA projection of the rib cage, if we can even find an example of a PA projection of the rib cage. Right, that was my lecture on ribs and sternum. This is our first new procedures lesson for rad procedures 3 and 4. Welcome back from your break. I hope you guys had a lovely break. I will be, as a reminder, I'll be going on vacation from Wednesday of the first week until Tuesday of the second week, and Monday is the total solar eclipse. I offered you a recorded lecture for that day. So if you're free and you got enough gas in your tank, for God's sakes, drive to the eclipse. Don't miss out. It's going to be 20 years before we see another one. I might not even be alive the next time another one comes through. If you didn't see the one in 2017, you owe it to yourself to see this one. So I will see you guys on the Wednesday after the eclipse, and I'll have, hopefully I'll have in short order, maybe not exactly on the Wednesday, but I'll have plenty of pictures from my telescope and my cell phone of the total eclipse. And I'll make a little, maybe I'll make a little PowerPoint to share with all my students and my experiences up there. So, all right, guys, we went over the anatomy of the ribs. Make sure you study that, the anatomy of the sternum, the 3 parts of the sternum, the difference between true, false, and floating ribs. Remember, floating ribs are a subsection of the false ribs. The ribs have a head, a neck, and a tubercle. They have 2 facets, one on the head and one on the tubercle. The facet on the head forms the costovertebral joint, and the facet on the tubercle forms the costotransverse joint. We discussed procedural considerations. Necklaces, earrings, and body piercings are, and also brassiers, are going to be artifacts that obscure pertinent anatomy if they're left in the left on the patient as the exam commences. Okay, no reason not to shield, regardless of what position, what projection we're doing. Okay, proper use of positioning aids. The angle sponge is going to come in handy if you find yourself doing a table version of either of these examinations. And again, we're going to be assessing whether it's trauma or non-trauma. That's going to be the primary consideration, and whether the patient has the stamina to stand up for the exam, or whether they're going to be swaying in the breeze and or fainting out on us. We definitely don't want to do. You could do a sternum exam upright with them sitting if you can get their knees underneath the vertical bucky. So just sort that one out. You can give it a try, but they are going to have to shimmy up to the vertical bucky, kind of lean into it for that sternum exam sitting. Okay, but perfectly acceptable to do a sternum exam sitting if your patient is too tired to stand. Okay, we will do simulations of these exams in practice, and then we'll review them as we go into the skull. As I start teaching you skull positioning, I'm going to say, okay, we covered the rib series and the sternum series, so somebody get up here and show me how to do this projection or that projection or whatever, and that way we'll have reinforcement of those. And I might even go a throwback to a previous semester, have someone demonstrate a T-spine to me or a C-spine to me just for giggles. So be on your guard for that. Remember, we haven't had the practical for the spine yet. That will be coming, so it certainly is fair game for me to expect you to practice that as we open labs for the ribs and the sternum. Okay, we'll be doing image critique for the ribs and sternum. I will have to spin up a schedule for the seniors to come back and visit us. Especially going to hit, we did have some of them that either forgot or were rescheduled due to a snow day or some other cancellation, and so I'll be sure to bring them back. And we have some opportunity for them to do some guest image critique, at least through RAD Procedures 3, maybe through RAD Procedures 4. We'll have to see what we're covering. Anyway, that's the end of this one. Make sure you review this before we go over it in laboratory session, and I can't wait to see you guys. Take care. Enjoy the rest of your break week, and I'll see you on Monday.